Hi everyone, I'm Alessia Pellerino, a neurologist and neuro-oncologist working in Torino at the Department of Neuroscience of the University and City of Health and Science Hospital. I am the leader of the subdomain 10.10 of the EURACAN, which is primarily focused on ultra-rare primary brain tumor, where the evidence-based data regarding the optimal diagnostic tools and/or therapeutic approaches are lacking due to their rarity. I have chosen an exemplary type of ultra-rare brain tumor for this presentation, which are the primary meningeal melanocytic tumors. So here's my disclosure. Primary meningeal melanocytic tumor of the central nervous systems include a spectrum of extremely rare tumors that arise from melanocytes originating from the neural crest that invade the leptomeninges or the choroid plexus during embryogenic development. The World Health Organization identified as a circumscribed leptomeningeal lesion or a diffuse multifocal leptomeningeal dissemination. In general, a melanoblast can give origin to 4 different melanocytic tumors. A differentiated circumscribed melanocytic tumor, which is a benign nature, is known as meningeal melanocytoma, while the malignant counterpart is represented by the meningeal melanoma. Conversely, diffuse meningeal melanocytic tumors are characterized by multiple linear or nodular lesions along the cranial and or spinal leptomeninges. Based on the histological features, a benign or malignant histological phenotype may be recognized, known as primary diffuse leptomeningeal melanocytosis or melanomatosis, respectively, with distinct molecular profile. In general, there is a lack of a large cohort that describe the correlation between histology, molecular features, radiological findings, and clinical course. Traditionally, primary meningeal melanocytic tumors do not have specific clinical or radiological peculiarities and may mimic a septic meningitis when spread along the leptomeninges, thus posing remarkable diagnostic and therapeutic challenges. Primary meningeal melanocytic tumors are considered extremely rare since they are not captured by prospective tumor registries. Therefore, it is difficult to estimate the exact population-based incidence. A retrospective cohort of 116 patients with primary or metastatic melanotic lesions of the central nervous system led by the Yale Cancer Center between 2001 and 2019 has identified only 4 patients who met the histological criteria of primary meningeal melanocytic tumors, with a relative incidence of this tumor of 3.4%. Primary meningeal melanocytic tumor can be part of the clinical manifestation of neurocutaneous melanocytosis, a sporadic and rare congenital neurological disorder characterized by abnormal aggregation of neomelanocytes within the central nervous system associated with large or giant congenital melanocytic nevi. Congenital melanocytic nevi is a pigmented skin lesion more than 20 cm of diameter or 40 cm for giant lesion in adult patients, composed of aggregate melanocytes in a delimited area of the body with overlying hypertrichosis with an increased risk of malignant transformation. Moreover, congenital melanocytic nevi presents a distinct unique distribution that provides garment appearance as an expression of developmental disorder of melanocyte precursor from neural crest. Congenital melanocytic nevi has an estimated prevalence of 1 on 50,000 to 1 to 200,000 and an incidence of 0.5 to 2 new cases per 100,000 persons per year. Typically, congenital melanocytic nevi patients without leptomeningeal involvement are asymptomatic and show a normal life expectancy. Conversely, symptomatic congenital melanocytic nevi have a poor prognosis due to the development of neurological complications, with a significant association with dental worker or Chiari malformations, hydrocephalus, and primary meningeal melanocytic tumor-related symptoms, such as seizures or focal deficit, and so on. Approximately 10 to 15% of patients with congenital melanocytic nevi syndrome develop meningeal melanocytomas, and other 23% of patients present a radiological central nervous system involvement without any symptoms. Primary meningeal melanocytic tumor can also occur in patients with BAP1 tumor predisposition syndrome, germline BAP1 mutation that confer a higher risk of meningeal, uveal, and cutaneous melanomas, as well as the tumor type, including mesotheliomas and clear cell renal cancers. Meningeal melanocytomas and meningeal melanomas account for 0.06 to 0.1% of the total meningeal tumors. Meningeal melanocytomas have an estimated incidence of 1 to 10 million persons per year, while an annual incidence of 0.005 cases per 100,000 population has been reported for meningeal melanomas. Meningeal melanocytomas can occur at any age, with a prevalence in the 4th, 5th decades and a median age ranging from 45.6 years to 53.7 years, while the median age at diagnosis of meningeal melanoma is 48 years in adult population and 3 years for children. Meningeal melanocytomas and melanomas often arise from the cervical and thoracic spinal cord with a dural-based implant or from spinal nerve roots. Cranial leptomeningeal involvement is less frequent, with a brain parenchyma invasion and often a predilection of trigeminal cave and cranial base. Meningeal melanocytomas may be associated with nevus of Ota, or ocular dermal melanosis, which is a benign melanosis that involves the distribution of the trigeminal nerve, mainly the ophthalmic and maxillary divisions, with associated hyperpigmentation of the eye and the nexus. The intraventricular or intramedullary localization of meningeal melanocytoma or melanoma is particularly rare, while a CNS isolated intraparenchymal presentation may suggest a metastatic melanoma. Meningeal melanomas may rarely spread extracranially with bone, liver, and lung metastases. Since diffuse meningeal melanocytic tumors are considered ultra-rare entities, the exact population-based incidence is unknown. Primary diffuse leptomeningeal melanocytosis are often associated with large or giant congenital melanocytic nevi and may have an aggressive clinical course. Neurological symptoms depend on the site of presentations and progress rapidly in case of malignant transformation, in case of transformation in primary diffuse leptomeningeal melanomatosis, with seizures, increased intracranial pressure, and hydrocephalus. Focal symptoms including aphasia, motor or sensory deficits, scotoma or blurred vision or impaired visual fields, cerebral signs, gait disturbance, and ataxia. Similarly, spinal symptoms reflect the level of spine compression and leptomeningeal involvement with para or tetraparesis, sensory levels, radicular and or back pain, urinary or bowel disturbances. Primary diffuse leptomeningeal melanocytosis patients can be asymptomatic for a variable period of time, but when neurological symptoms have developed, the prognosis is remarkably poor. Primary diffuse leptomeningeal melanomatosis is a devastating disease with a rapid evolution and a dismal prognosis. The increased intracranial pressure, hydrocephalus, headache, and meningeal and radicular symptoms are the main neurological complications, and the ventriculoperitoneal shunting provides a palliative effect, but with a higher risk of peritoneal melanomatosis. Primary meningeal melanocytic tumor, either circumscribed or diffuse, show a spectrum of histopathological features ranging from blue nevus light, well-differentiated neoplasm to melanoma. A summary of the essential diagnostic criteria according to the WHO classification of tumor of the central nervous system's 5th edition for the tumor covered in this guideline is presented in the table shown in the slide. Starting with meningeal melanocytoma, we know it is a circumscribed melanocytic neoplasm with a bland histological appearance. Tumor with increased mitotic activity of the invasion of a central nervous system parenchyma have been defined as melanocytoma of intermediate grade. Well-differentiated melanocytomas may show variable cell density but are usually composed of densely packed, slightly spindled or oval tumor cells containing variable, often abundant melanin. Heavily pigmented tumor cells and melanophages are especially seen at the periphery of the nest. Seldom amelanotic melanocytomas have been described. The nuclei are oval or bean-shaped, occasionally showing grooves, with small eosinophilic nuclei, the spindle type A. Cytological atypia, necrosis, and mitosis are typically absent. Meningeal melanocytomas generally do not show invasion of central nervous system parenchyma. According to the WHO definition, meningeal melanocytic tumor with the histology of melanocytoma but showing CNS invasion or increased mitotic activity have been defined as intermediate grade melanocytic neoplasm. Meningeal melanoma is a malignant circumscribed meningeal melanocytic neoplasm that arises from leptomeningeal melanocyte with aggressive growth properties. Meningeal melanomas are composed of pleomorphic spindle type B and or epithelioid cells with variable cytoplasmic melanin and polymorphic nuclei that give large irregular eosinophilic nucleoli. Numerous mitotic figures can be seen. They often demonstrate an equivocal invasion of a central nervous system parenchyma and or necrosis. Meningeal melanoma may spread through the subarachnoid space. The melanocyte of circumscribed meningeal melanocytic neoplasm express common melanocytic marker by immunohistochemistry. Loss of function hemizygous mutation of BAP1 combined with chromosome 3 monosomy can be revealed by absence of BAP1 protein expression. Molecular pathology is comparable to uveal melanoma, with mutually exclusively activating hotspot mutation in GNAQ, GNA11, PLCB4, and CISLTR2 that are considered the first step in the oncogenesis of the circumscribed meningeal melanocytic tumor. GNAQ and GNA11 mutation are most frequent, observed in about 60–70% of cases. Meningeal melanocytoma and melanomas do not usually harbor HRAS, KRAS, BRAF, or KIT mutation. Third promoter mutations are also usually absent. Likewise, in uveal melanoma, a mutation in AIF1AX, SF3B1, or BAP1 is considered a next step in the oncogenic process. The possible adverse prognostic relevance of this mutation, well described in uveal melanoma, requires further validation in meningeal melanocytoma of intermediate grade and melanoma. The chromosomal alteration and methylation pattern identified in circumscribed meningeal melanocytic neoplasm, uveal melanomas, and blue nevus-like melanoma show common DNA methylation and copy number alteration. Diffuse meningeal melanocytosis is a diffuse or multifocal neoplasm of cytological bland melanocytic cells of variable shape and pigmentation that remain within the subarachnoid and Virchow-Robin spaces. Nuclei are bland with the anchoscipous nucleus. Histological bland lesions that show unequivocal invasion of the central nervous system parenchyma should be considered as meningeal melanocytosis. Diffuse meningeal melanomatosis is a diffuse or multifocal proliferation of melanoma cells that often show CNS invasion. Nuclei generally show marked atypia with large eosinophilic nucleoli. Mitosis and/or necrosis also warrant a diagnosis of meningeal melanocytosis. The melanocyte of meningeal melanocytosis and melanomatosis express common melanocytic markers by immunohistochemistry. However, it should be remembered that the SOX10 and ACE100 will not discriminate melanocytes from astrocytes. Molecular pathology shows that both cutaneous and diffuse meningeal melanocytic neoplasm associated with neurocutaneous melanosis derive from a single post-zygotic somatic mutation in NRAS or BRAF. In one case of isolated leptomeningeal melanocytosis, an NRAS mutation was identified. Third promoter mutations have not been investigated in this context thus far. Progressive diffuse meningeal melanocytic neoplasm showed an increase in copy number variations similar to those described in cutaneous melanoma. Alternatively, amplification of the mutated NRAS gene has been described. Cerebrospinal fluid molecular testing has been proven feasible to achieve an early diagnosis of primary diffuse leptomeningeal melanomatosis. In 3 cases, the diagnosis was solely achieved by cerebrospinal fluid cytology. Baumeter et al. Have found that an NRAS Q61R mutation in both tumor tissue from biopsy and CSF liquid biopsy. The mutant allelic frequency was higher in CSF, 3%, as compared with the tumor tissue, 1%, suggesting that CSF liquid biopsy could recapitulate the molecular aberration of primary diffuse leptomeningeal melanomatosis. Imaging is firstly needed to exclude a melanoma metastasis in CNS. Magnetic resonance imaging can suspect a melanocytic nature of the lesion, as further explained, but cannot diagnose a primary or secondary origin. Therefore, when a melanocytic tumor is suspected, the existence of a systemic disease should always be excluded, with a thorough clinical examination and a whole-body imaging study that include 18F fluorodeoxyglucose PET-CT, gastrointestinal endoscopy, as well as skin and eye examination. Spine MRI should also be done to inform on spread along the whole neuraxis. Computed tomography is commonly used as first in neuroimaging assessment, especially in emergency setting. On CT scan, a melanocytic neoplasm is often hyperdense, therefore mimicking hemorrhage, and has a variable degree of homogeneous contrast enhancement. Calcifications are rare, but can be seen in melanocytoma. Acute hydrocephalus can be a radiological finding at presentation in leptomeningeal subtypes. On MRI, melanin is typically hypertense in T1-weighted sequences and hypointense on T2-weighted sequences as a reflection of its paramagnetic effect, which shortens T1 and T2 relaxation times. Melanocytic lesions also show a substantial signal loss and successively weighted sequencing. This phenomenon, also known as blooming artifact, seems to origin from deoxyhemoglobin, a strong paramagnetic molecule, rather than melanin pigment content by itself, and is probably a result of several microbladings and metascavenging melanin properties. Intratumoral microhemorrhages developed over time and can be absent in early melanocytic lesion. As a consequence, the susceptibility weight imaging can be negative at initial stage. Of note, the collection of this evidence arises from in vitro and in vivo analysis conducted on melanoma metastases and not on primary melanocytic tumor of the central nervous system. Nevertheless, it is reasonable to believe that this phenomena also occur in the primary CNS counterpart. Radiological pathology correlation studies on melanoma metastases have also shown that the degree of melanocytic content correlates with T1 shortening. This explains why lesions with a poor melanoid content, less than 10%, do not have the typical T1 hypersensitivity and are therefore radiologically defined as amelanotic lesions. Conversely, a clear association between T2-weighted hyperintensity and melanin content has not been shown. Neuroimaging also distinguishes between a circumscribed and a diffuse lesion pattern, but doesn't inform on the degree of lesion aggressiveness, and doesn't distinguish a melanoma from a melanocytoma, or a melanocytosis from a melanomatosis. Melanocytoma and melanoma are usually solitary and show a predilection for the posterior fossa, naked cave, and cervical spine cord. This location seems to reflect the site in which leptomeninges have higher concentration of melanocytes. On the contrary, supratentorial lesions are rarer. In the spinal canal, most of these tumors are in the intradural extramedullary compartment, but occasionally can also be seen extradural or intramedullary. A retrospective case series of 16 patients with pathological proven spinal meningeal melanocytomas show typical melanocytic lesion signal characteristics influenced by intratumoral hemorrhage and no peritumoral edema or syringomelia. Intravertebral foramen can be enlarged and be erroneously interpreted as a neurogenic tumor. PET-CT shows intense 18F fluorodeoxyglucose uptake and inform on the disease extension. Given the rarity of the disease, many conditions may mimic a primary melanocytic tumor. Extra-axial circumscribed lesion can morphologically resemble a meningioma. Acellular locations may be indistinguishable from a hemorrhagic pituitary macroadenoma, while a leptomeningeal spread should evoke more common causes of subacute meningitis, for example, infective autoimmune or other tumor pathology. In the absence of T1 leptomeningeal hyperintensity, preoperative suspicion is almost impossible. As the leptomeningeal proliferation is often present in these patients and results in leptomeningeal enhancement, neuroradiologists should choose to perform a 3D FLAIR delayed post-contrast sequence, which is, to date, the sequence with the highest sensitivity for leptomeningeal contrast enhancement evaluation. Brain MRI protocol should therefore include 3D T1 spin echo sequence before and after contrast injection and a 3D FLAIR post-contrast sequence. Susceptibility imaging could also be added to inform on bleeding lesion status. Of note, a spontaneous T1 hypersensitivity in a melanotic lesion may also reflect intratumoral bleeding instead of melanin, as extracellular methemoglobin is strongly paramagnetic, resulting in T1 hypersensitivity. However, hemorrhages has different stages and evolves in time, changing MRI signal characteristics, while melanin signal alone does not change over time. In conclusion, the rarity of this tumor type and the impossibility of distinguishing between primary and secondary melanoma preclude the preoperative radiological diagnosis. Intratumoral hemorrhage largely influences the imaging appearance of a melanocytic lesion and can mislead the CT and MRI interpretation. Nevertheless, imaging is requested to exclude a systemic disease and can narrow the differential diagnosis by suggesting a melanocytic lesion. In addition, it shows a circumscribed or diffuse lesion pattern, thus guiding surgical decision and pathological integrated diagnosis. This is a case of diffuse meningeal melanomatosis in a 14-year-old boy. In the first and second column, figure A, 3D T1 weighted sequencing. In figure B, 3D flare sequence. In figure C, 3D T1 weighted after contrast injection. And in figure D, 3D flare images after contrast injection. This case displays the ability of the delayed 3D flare sequence to show leptomeningeal disease better than T1 weighted post-contrast sequences. Some examples of this increased visibility. In the figure E and F is another case of diffuse meningeal melanomatosis. In the figure E, in particular, the 3D T1 weighted before contrast injection, showing small focal areas of spontaneous T1 hypertensity. And in figure F, the sagittal T1 weighted sequence showing an extensive medullary involvement of the disease. This is another case. You can see an axial T2 images, figure A, flare images, figure B, T1 sequence, figure C, and T1 weighted post-contrast scans, figure D, of a 67-year-old woman that display a parietal meningeal melanocytoma. And moreover, another example, here you can see a T1 weighted images with gadolinium. The figure A shows a newly developed hydrocephalus with the leptomeningeal enhancement along cranial nerves and both linear and nodular lesion around cerebellum, quadrigeminal lamina, hypophysis, corpus callosum, internal auditory canals, and pontus cerebral angle. And in figure B and C, we can see a diffuse leptomeningeal enhancement, especially in the conus medullaris. Now, talking about treatment modalities, we start with local therapies, in particular with surgery. There is only a handful of papers on surgical management on primary melanocytic tumor of CNS, all of them being case report or small case series. Usually, at time of surgery, the diagnosis is still unclear. This tumor, when occur as solitary lesions, are attached to the dura and may be interpreted as meningiomas. Therefore, surgical strategies is made according to meningioma management and comprises the compression of adjacent neural structures and complete removal of the tumor, including the involved dura. This simple meningioma-derived surgical strategy seems to be appropriate for melanocytic tumor of the central nervous system. In particular, in a series of 17 meningeal melanocytic tumors, 4 melanocytomas and 13 malignant melanoma, reported by Rath and colleagues, meningeal melanocytomas did not recur after a gross total resection. Conversely, 8 out of 13 patients with meningeal melanoma recurred after surgery, with 4 being fatal with a median survival of 14 months. Of the 5 totally resected meningeal melanomas, 4 patients did not recur with a median follow-up of 26 months, while only one patient recovered after a median follow-up of 26 months. This is also supported by even smaller series, comprising 5 cases, each from French et al. And Jaiswal et al., who also recommended a complete resection for either meningeal melanocytomas or melanomas as main goal of therapy. Recommendations for radiotherapy are based on expert opinion according to the available literature and general principle for treatment of brain tumor, as the reported cohort of case series are too small for data-driven analysis. Decision-making should be based taking the following parameters into account: benign versus malignant histology, circumscribed versus diffuse pattern, complete versus incomplete resection. High-dose radiotherapy is rarely indicated in diffuse melanocytic tumor, except as palliative treatment to alleviate symptoms if appropriate. In the largest series by Puyana et al., a total of 54 patients retrieved from the SEER database from 1973 to 2015 were analyzed. Patients received a gross total resection in 40.7% of a subtotal resection in 7.4%, adjuvant radiotherapy in 46.3%, and chemotherapy in 27.3%. Most favorable outcome was achieved the gross total or subtotal resection followed by postoperative radiotherapy. No survival benefit was achieved with subtotal resection, radiotherapy, or chemotherapy alone. Therefore, general agreement exists that radiotherapy should be employed after subtotal resection and should be considered in localized malignant melanoma, even after gross total resection, as a considerable proportion of patients in the SEER series had received postoperative radiotherapy. After biopsy only or relapse after gross total with high-dose radiotherapy can be employed to delay complication from further growth, although no impact on overall survival can be expected. Conventional fractionative radiotherapy with up to 60 gray has been mostly employed, although radiosurgery has been used for selected patients with smaller tumor and up to 3 lesions. Therefore, in postoperative and primary setting, 60 gray in 1.8 to 2 gray are recommended with a clinical target volume margin from 5 to 10 mm, as in primary malignant tumor of the brain, respecting natural anatomical barriers. Systemic therapy should be considered in case of residual or progressive disease of meningeal melanocytoma or melanoma, when surgery and/or radiotherapy have been exhausted, or in patients with primary diffuse leptomeningeal melanocytosis or primary diffuse leptomeningeal melanomatosis. Considering the diffuse infiltrative pattern of primary meningeal melanocytic tumor and the significant radioresistance, medical treatment are considered as salvage therapy. Nevertheless, the role of systemic therapy, including traditional chemotherapy, targeted therapy, or immunotherapy, remains to be clearly defined. Of note, uveal melanoma show different activating mutation with melanocytic tumor, including GNAQ or GNA11, BAP1, or SF3B1 mutation, with the emergence of targeted and epigenic therapeutic strategies for the metastatic setting. However, clinical trial or prospective studies focused on melanocytic tumors are lacking, and their management is still based on case reports or applying lines of treatment used in leptomeningeal diffusion from extracranial metastatic melanoma. Systemic therapy has displayed a limited efficacy in terms of disease control, as you can see on the results that I have reported in the table that you can see in the slide. Regardless of the type of treatment, including either intrathecal chemotherapy via Maillard reservoir with etoposide, cytarabine, and topotecan, and systemic therapies such as interferon alpha, temozolomide, everolimus, trametamide, nivolumab alone, or in association with ipilimumab. Anecdotal report of efficacy and prolonged overall survival have been reported with different chemotherapy regimens, including temozolomide plus cisplatin, plus vindezy, plus big interferon alpha 2b, with 11 months of overall survival, or temozolomide in association with carboplatin and etoposide with an overall survival of 24 months, or cisplatin in combination with dacarbazine and whole brain radiotherapy with an overall survival of 12 months, or other example when temozolomide was employed as first-line treatment followed by intravenous thymosin recurrence, achieving an overall survival of 24 months, as you can see in the slide. Whether the activity of the main treatment used in metastatic melanoma, such as the checkpoint inhibitor with programmed cell death PD-1 or cytotoxic, the lymphocyte-associated protein 4 CTLA4 blocking antibody, or the combination of BRAF or MEK inhibitor, may be an effective treatment for therapeutic option for primary meningeal melanocytic tumor remains to be elucidated. Overall, the benefit from immunotherapy or BRAF MEK inhibitor is weak, according to a few case reports on primary diffuse leptomeningeal melanoma. In conclusion, a definitive advantage of one specific therapeutic approach over another could not be concluded, and despite the treatment effort, the median overall survival remains poor, ranging from 4 to 12 months from the diagnosis. So, running to the conclusion of this presentation, primary meningeal melanocytic tumor are the paradigm of ultra-rare brain tumor and represent a challenge in terms of diagnosis and treatment. Molecular analysis is helpful for the diagnosis of primary meningeal melanocytic tumor. The detection of GNAQ, GNA11, PLCB4, and CISTR2, as well as the methylation profiling, can support the diagnosis of this tumor as primary CNS neoplasm and discriminate them from other melanocytic lesions, including brain or leptomeningeal metastases from melanoma or malignant melanocytic nerve sheath tumors. Furthermore, some additional molecular alterations such as SF3B1, AIF1AX, and BAP1 mutation confer a significant aggressive course in meningeal melanoma, while both primary diffuse leptomeningeal melanocytosis and primary diffuse leptomeningeal melanoma are often NRAS mutated and rarely BRAF mutated. Neuroimaging displays the extension of the disease and patterns of progression, but does not inform clinicians regarding the aggressiveness of the disease and can be misunderstood with other causes of aseptic meningitis. Despite the advances in molecular profiling of primary meningeal melanocytic tumor, strong evidence regarding the optimal management is still lacking and based on anecdotal reports or small cohort. Overall, the prognosis is better for circumscribed meningeal melanocytoma and melanoma, especially in case of gross total resection. Conversely, as the prognosis of diffuse meningeal melanocytic tumor is remarkably poor, an improvement of knowledge and correlation between histology, molecular features, and clinical course should be pursued to achieve an early diagnosis. This issue could be addressed throughout a strong collaboration and multidisciplinary network to build and maintain dedicated platform and registry for sharing patients' characteristics, therapeutic intervention, outcome, and correlation with molecular profile of primary meningeal melanocytic tumor. Thank you so much for your attention.